Good evening, everybody. Thank you for joining us for our live Q&A session tonight. My name is Michaela Grogan, and I'm a marketing assistant here at Caring Medical. I just want to go through a few little things for the night before we get started. So we do have some questions that were already prepared that were submitted when you signed up. It'll be over prolotherapy, cervical instability, about our office, and then a few other things. All of the participants will be muted and hidden. So if you do have any questions, you can utilize the Q&A box at the bottom of the screen. And our team will try to answer them as promptly as we can. And then at the end of all of those questions, we will be going over a few case studies. And yeah, so it is my pleasure to introduce Dr. Hauser.
Hello, everybody. Appreciate everybody being here tonight. Appreciate you guys subscribing to the YouTube station and wanting to get better from your various symptoms. All of us are in the battle to get the word out that ligamentous cervical instability and neck problems cause anything from eye conditions. In the office here, I see a lot of blurry vision. Ligamentous cervical instability or neck problems can cause swallowing difficulties. Just this week, I saw a couple new cases of gastroparesis where the vagus nerve was not innervating the stomach. And then because of the dilation of the stomach, then it was causing heart problems. So probably about a few months ago, I just thought back in the day, like when I was younger, I'm 62 now. So when I was younger, they would have like live radio. People would call in and you could hear the conversations between the host and the people that would ask questions on the radio. And I think we're kind of losing some of that. So I at least wanted to try one time where I could get people who I haven't seen and maybe get a dialogue and you could learn from that dialogue. So we're going to try today where a couple of people from around the world where we talk about their case, people that I haven't seen. And then the other thing too is you guys probably have common problems that it would be nice if I could just get on and answer your questions. So hopefully we're all going to learn. And I just want to assure you that you can get better. You can get better. I know sometimes when you have a chronic illness and the doctors say that they don't know what's wrong, or they say that your condition is in your head, like you got anxiety or depression. Well, I got news for you. The doctor's going to be depressed and anxious if they had a chronic stomach problem and they were losing weight and nobody could figure out the cause. Well, I'm here to tell you that often the cause is actually found in the neck. And if you want to Google, if I was going to say just a couple things to encourage you to dig deeper into this subject, type in Frontiers of Neurology, Ross Hauser, internal jugular vein, because I just recently got a article published how the forward head face down lifestyle causes blockage of the jugular vein. The other article that I'd encourage you to read, because as you know, I try to write and talk in easily understandable language. So the other article, type in Lupine, Lupine publishing, and just type in Hauser's laws. And so that's a very, very good article on how ligamentous joint instability causes various conditions. So I'm just going to start with the questions that you guys asked. Can prolotherapy be effective for hand pain? Basically, the weak link in the musculoskeletal system are the ligaments. So the very first sign on MRI, when they've done like hand arthritis, the very first sign of arthritis is at the ligament bone juncture. That's called the fibroosseous junction. So it just shows that arthritis starts at the ligaments, called the entheses, and prolotherapy injections are done right at that entheses. So prolotherapy definitely helps all different kinds of arthritis in the body. Somebody asked, hey, I can't do chiropractic care and my spinal curves aren't so good. What else can I do? Well, you just saw Michaela You just saw Michaela, and that's Michaela's baby, Levi. So you could see Levi working hard on his neck structure. And you hear me on YouTube all the time saying we need to have a face-up lifestyle, not a face-down lifestyle. So I encourage everybody, you have got to, with your cell phone and your computer, you got to be looking up. So I think another good thing is to be like Levi and have your cell phone here. So when you're looking down at your cell phone on your stomach, you're using your neck muscles. The main thing is when you're walking, when you're working, just use your neck muscles. The number one reason why I think the ligaments in the spine get loose is because of slouching. Because let's be honest, if we slouch in a chair, you lose the lumbar curve and you lose the cervical curve, and the ligaments get stretched out over time. So if we would just raise our chest and be looking up at a cell phone or looking up at a computer, our spinal curves would get much, much better. Is there such a thing as too soon starting prolotherapy? I would say no. I mean, traditionally, prolotherapy is used for chronic pain of a joint that has a ligament etiology or a tendon etiology. All the structures of the joint, the meniscus, the labrum, the tendons, the ligaments, the cartilage, they're white. White means that their repairability is very limited. So prolotherapy is used to stimulate the repair of these structures. So for instance, if I had a very bad bike accident and I knew I tore a bunch of stuff in my hip, I would start prolotherapy right away. There's some doctors who would say, you know, the body heals over a 4 to 6 week period. You should wait after the injury 4 to 6 weeks, but I've had athletes come in right away after an injury, so you can start it right away. If you're receiving PRP now, remember there's plenty of doctors, they'll inject PRP into the joint, but remember the primary problem that's causing the looseness in the joint are the ligaments which are outside the joint. So if you are getting PRP, you have to make sure that the doctor is treating the ligaments, and specifically they have to treat the ligaments where they attach to the bone. So a lot of times when I review charts of people, and there was a time period where it seemed like 1 out of 10 patients had seen another doctor who gave them PRP or prolotherapy, but it quote unquote didn't work. When I reviewed the charts, it seemed like the doctor wasn't being very comprehensive. So when we do a lower back, somebody might get 60 shots because it's like spot welding. Even a thumb, just a simple thumb joint might be 15 shots because they're specifically done where the ligaments attach to the bone. You gotta hit the bone. So if the doctor is just giving shots inside the joint, well, that's going to swell the joint. So that could even be a reason why somebody's prolotherapy or PRP actually made them worse, because the doctor was putting too much solution in the joint when the real problem with the instability is outside the joint. But let's say that if somebody was doing the right technique of PRP prolotherapy and the treatment wasn't stimulating enough healing, what you can do is get treated more frequently. Like there are people, especially people fly in. I recently saw a patient from New Zealand, and we often see people from Europe. So some of the people, they're so severely disabled that they'll actually stay here for a couple months. And I call it the fast track. I'll see them every 2 weeks just to induce healing quicker. So sometimes you got to get treated more frequently, and sometimes you got to use bone marrow. You got to use lipoaspirate fat. There's stem cells in the lipoaspirate and the stem cells, so sometimes you do have to resort to that. Sometimes also you have to treat the surrounding joints. So I call these co-structural morbidities, meaning that somebody could have neck pain, right? They have neck pain, but there's muscles that attach from the neck to the thorax, from the neck to the lower back. So if you have like clicking, popping, grinding in your neck, but you also have clicking, popping, grinding in your shoulders, in your thoracic, in your lower back, it may be that you have to actually treat those areas also. Now, somebody said that, could curve correction and PRP help my Nutcracker syndrome? So there are various syndromes: median arcuate ligament syndrome, superior mesenteric artery syndrome, Nutcracker syndrome, where, and this is my viewpoint, there is some Hauserian philosophy, in obviously the things that I believe. But the reason that is, like, think about, like, somebody might have carotid artery obstruction here on the right side, but it's not on the left side. In other words, the doctor says you have atherosclerosis of your carotid artery. It's like, well, why is the one side all full of plaque and the other one isn't? So, in other words, there's conditions that I think in many people have a structural etiology. So there's various conditions where the blood supply, or in Nutcracker syndrome, the renal artery gets obstructed, and it's sort of like why in certain position it gets obstructed and the person has like unbelievable pain. So they have just unbelievable pain. And then other times they don't have as much pain. Why? Well, I think when you have symptoms that are positional, like you can get in a certain position and the symptom goes way down or goes way up, to me, there's a structural etiology. So if you look at what does the median arcuate ligament attach to, or what do, like, the renal vein, the mesenteric artery, like, where are they located and what ligament attachments are near there, you'll see that it's basically the thoracolumbar junction. And, like, in other words, the diaphragm attaches to the thoracolumbar junction, and the diaphragm also attaches to the ribs and the sternum. So the question to ask yourself, the person who asked this question, do you have clicking, popping, grinding here, or do you have clicking, popping, grinding here? If the answer is yes, then I would say that you have a ligamentous joint instability etiology of your Nutcracker syndrome or your median arcuate ligament syndrome. So the first thing to do is maybe wear something like the body braid, or wear some kind of brace, so the brace is stabilizing you, and see if this symptom gets better. If it gets better, then consider getting prolotherapy to those loose joints. So somebody said, I have severe back muscle spasms due to a disc-related problem. Can prolotherapy help in this situation? So recently, I consulted with Danielle Matus, my associate, and a person had a really bad herniated disc. And basically, at the very level that they had the herniated disc, they had joint instability. So we document joint instability by digital, DDR. Dynamic digital radiography. Sorry about that. So it's live because dynamic digital radiography. So in other words, we had the person doing this. So most disc problems, they occur in an area where there's instability. So prolotherapy works very good. And you've heard me say over and over again that if you have chronic muscle spasm, you probably are having it because the body's trying to stabilize that area. That's why you get a massage or you do physical therapy and it never seems to cure it, because the underlying problem is a ligament problem. It's not a muscle problem. The muscle problem is secondary. So when you tighten the ligaments, the muscle spasms go away and you just feel much, much, much better. Hey, do you think that insurance companies will cover prolotherapy in the future? Does your office offer payment plans? We are an office payment at the time of service. They're getting more and more insurance companies, especially independent insurance companies like Christian Healthcare Ministries and different self-insured companies are more and more paying for prolotherapy and regenerative medicine. So it looks good. And in the United States, they're going to look at, again, with the new administration, they're going to look at what should be covered and what isn't covered. This is kind of common, this next question. The patient says that they believe that all their things could go back to their childbirth. Well, it turns out anybody who's seen a C-section, so in medical school I did obstetrics and gynecology, and if you when the doctor takes the baby uh, out of a C-section, there's a torquing of the head. And then with a forceps delivery, there's a torquing of the head. So I believe that you could, even in the birth, the baby have some vagus nerve issues. And you hear me say this over and over again. So basically, I would ask this person, were you a colicky baby? Like, were you a colicky baby? Did you have regurgitation? Did you have a lot of food allergies or allergies growing up? And if the answer is yes, it's likely that you had a vagus nerve problem your whole life. So it's not uncommon for me to see a patient where the patient will tell me, Doc, I've had this problem for 40 years. And the neat thing about it is, if say the person has a vagus nerve problem from a neck issue that they've had for 40 years, if you actually correct the neck issue, it's unbelievable how many things can get better, right? Because if you get at the root cause of the problem can get resolved. So basically, how many prolotherapy injections are done depends on the area. Like the shoulder is about 30 shots, the neck's about 50 shots. The TMJ is probably about 6 shots, lower back 60 shots. So it's a lot of shots. But with a skilled prolotherapist, the treatments only take 5 to 8 minutes, depending on the joint that's done. So it doesn't take a long time. Oh, this is a good question. How do you ensure all other possible causes have been ruled out when a patient comes to see you? No, it's a good question. I mean, nobody can 100% say that a symptom is from a certain condition. Like one time I had a parent ask me, it was just a first visit, and the dad looked at me and said, I want you to say that it's 100% that the prolotherapy is going to get my son well. And I looked him in the eye, said, no doctor can say that. And I would even say, if a doctor gives you 100% assurance that a certain thing is going to cure you of a chronic thing, I'd say run out of that office. All a doctor can do is normally for this condition, like normally when somebody has ligamentous cervical instability and you have blurry vision, and by our neck vitals testing, you have cerebral spinal fluid around your eye nerve, and we open up your jugular veins and the fluid goes off of your eye nerve, normally the blurry vision goes away. But most of the patients that come to see us, they've already seen 5 to 10 physicians already. Like, in other words, they already had a million other causes already. So, Caring Medical, the Hauser Neck Center, we're basically the doctors of last resort often. So, but there definitely are times where I'll order autoimmune testing, or I'll change somebody's diet, or I'll order hormones. So it's not like we don't do some of the things, but anybody who's followed my career would know that 20 years ago, we had a comprehensive natural medicine center. We had a cancer center. I ran a cancer center. We had an IV center. We had diet typing where we did intricate diet testing. And it's like, why does Dr. Hauser now just do structural medicine? Well, you know the reason. I think the number one addicting thing in the world now, it's not cocaine, it's not marijuana, it's not caffeine, it's the cell phone. And you know that's true. It's like 98% of the population of the world has a cell phone. And if us together don't get the word out that you can't 10 to 14 hours a day be in this position and think something bad's not going to happen to you, you're very, very naive. So the more you guys learn about it, and the more I learn about it, and the more we get the word out, we're going to help so many people. Because I see now people in their 30s, their 20s, they're losing their memory. I have people that had very productive lives. They get ligamentous cervical instability, and now they have derealization and depersonalization. Like, they don't even feel like themselves. They're like, I'm in a different body, and it's so distressing. And the amount of headache and head pressure. And imagine somebody going along with visual snow, and every time they look at something, it's all blurry. And I'm just telling you guys, you can get better. you can absolutely get better. You just got to get your neck structure good. And if you have instability, you got to get prolotherapy. Now, we have an ozone generator in the office here. Prolozone in some people works. Like if a person doesn't have a lot of instability, in my experience, prolozone is going to work. But if you have a lot of instability, you're going to need other substances beside ozone to stimulate healing. But ozone has a lot of therapeutic effects in the body. So especially if somebody has arthritis of the knee, but there's not a lot of instability, and you just want to get the milieu, you just want to get the joint fluid to be healthier, prolozone's a good way to go. Is it possible to get back mobility, strength, and muscle tone once you've lost it? Yeah. I mean, obviously, a person can rehab better if they're stable. So if you've tried physical therapy and you're like, geez, it didn't do nothing, or it made me worse, it's probably that you had underlying ligamentous, pelvic, or lower back instability. So you probably need some prolotherapy. One of the tests that you can do it anywhere in the world, is just do flexion X-ray, extension X-ray, or you can do flexion MRI, extension MRI. Now, that's not going to be as good of a test that we do. When we do digital dynamic radiography, we're doing actual motion. So in other words, it's going to be more sensitive to do dynamic digital radiography because you actually have the momentum. But if you have to do a flexion extension MRI, if you have to do flexion extension X-rays, it's always good to, in my opinion, to take a muscle relaxant before you go to get that test, because you have to really, really flex and you have to really, really extend. If you go there with muscle spasm, it's not going to show the instability. So there's all kinds of substances that come out every few years. So in other words, the big thing right now is like stem cell lotions, And again, I would say that when somebody has a structural instability, like they have clicking, popping, grinding in their neck, in their shoulder, in their lower back, these kind of things are helpful, but they're not curative. I say often in the office, it's very easy to help somebody. It's very hard to cure somebody or to get like a disease into remission, right? Because you can just rest all the time. You could lay down all the time and you're going to feel better, but that's not really repairing what's injured. So in other words, the more stable a joint, the more these things, the lotions, the different things people take are helpful, like Prolozone. But once you have a lot of instability, it's like having a screw loose on a cabinet door, right? There's things you can do. You can hold the door, but ultimately you've got to get a Phillips screwdriver and do that. So the Phillips screwdriver in the human body is prolotherapy injections to where the ligament's damaged, and it'll stimulate repair to get the ligament thicker, stronger to resolve the instability. Like supplements help. For 25 years, I've used orthomolecular products. They're in Plover, Wisconsin. There's a lot of good supplement companies. So all the things are helpful. But again, it's helpful to help your body heal. But white structures of the body, to actually get them to heal, you have to induce them to heal with something like PRP prolotherapy, stem cell prolotherapy, or regular prolotherapy. Ehlers Danlos syndrome. Like if you want to know if you have Ehlers Danlos syndrome, then just do a Beighton score on yourself. So can your thumb hit your forearm? Can you bend your finger past 90 degrees? Can you hyperextend your elbows, hyperextend your knees? And can you touch the floor without extending or without flexing your knees? So, if you have a score of 6 or more, possibly even 5 or more, it's likely that you have hypermobility, Ehlers Danlos syndrome. So there's a criterion. If you go on Google and you type in 2017 Ehlers Danlos syndrome criterion, there's an actual form that we would fill out. Most people don't need to have a genetic test. Like there isn't a genetic test for hypermobility Ehlers Danlos syndrome. There's genetic tests for some of the other ones, but 99.99% of what I see and what's in the field of medicine is not the classic Ehlers-Danlos syndrome or periodontal Ehlers-Danlos syndrome. It's hypermobility Ehlers-Danlos syndrome. Okay, so let me, the clicker's not working. Okay. How can we understand Ehlers-Danlos syndrome created by an accident and invoke Ehlers-Danlos syndrome? So technically, Ehlers-Danlos syndrome is not caused by an accident. It can make the symptoms a lot worse because you could have a car accident or any sort of whiplash, like you could have COVID or you could have a respiratory infection and don't realize all this coughing is literally whiplash injuries of your neck. Remember, ligamentous cervical instability, it can cause pretty much anything, right? It can cause headaches, vertigo, blurry vision, palpitations, heart arrhythmias, stomach issues, leaky gut, right? Leaky gut. So what happens is you go to a doctor and they say you have Meniere's disease, or you go to a doctor and they say you have mold toxicity, or you got chronic Lyme. But if you research chronic Lyme, you're not supposed to make that diagnosis if there's another cause of your symptoms. So I'm just telling you, if you have cracking, clicking, grinding of your neck and you have a tension in your neck, it's likely your symptom is going to be from ligamentous cervical instability. So the only difference between joint hypermobility syndrome and hypermobility Ehlers-Danlos syndrome just means that the looseness of the joints are a little bit more with Ehlers-Danlos syndrome, but you treat them the same. I personally think most of the symptoms of Ehlers-Danlos syndrome and hypermobility syndrome is from ligamentous joint instability. So like if somebody has, let's just say they have numbness down the leg that nobody can figure out, if you just follow the sciatic nerve, you're going to see that there's either ligamentous joint instability in the back, the pelvis, the hip, right? If you move your hip and there's grinding, clicking, popping, it's likely that you have ligamentous hip instability. So the question is when you do prolotherapy in your average patient versus one with Ehlers-Danlos syndrome, is there any difference? The only difference is that Ehlers-Danlos syndrome patients often have other joints involved. So I often tell them the most important joint to get stabilized when you have a lot of symptoms and you have Ehlers-Danlos syndrome is the neck, because the neck, it can cause everything. And let's be honest, if we look at the vagus nerve and what the vagus nerve actually does, it's likely your body's ability to heal or repair, even the damage that's been done on your body today, right? All the cells are working. Like the reason why you rest at night is because your brain pressure has to go down at night. Your jugular veins are supposed to be open. Whatever memories you made today, the memories are consolidated in your hippocampus and different parts of your brain when you sleep at night. That's why if you don't sleep soundly, you start losing your memory, basically, your cognitive ability. And then all the cells of your body, the organs of your body, they need to rest at night and repair. Well, the way they do it is primarily through the vagus nerve. So if you have vagus nerve degeneration because your neck curve is reversed and your vagus nerve is getting damaged, you could see that all of a sudden, and like patients tell me, Doc, I'm just telling you, since my neck got all screwed up, it's almost like all the joints of my body are getting looser and looser and looser. So that to me means that they're losing the repair ability. So to regain the repair ability, I, as a physician, got to get involved in their sleep, so there's different things people can do so they get a good night's sleep. But a lot of it is figuring out what position is the jugular veins open. So that's some of the testing that we do in the office. So we'll look at not just your jugular veins in the middle of the neck, but your jugular veins at the atlas, because you always hear me talking, the problems at the atlas, the problems at the atlas. And some people have elongated styloids and don't realize when they're in bed and they're bent down like this, those styloid bones could be blocking their jugular vein. So that's why when you're sleeping at night, it's best to either support your neck, but don't have pillows that your neck is all flexed. And when you're sleeping on your side, don't sleep like this, but sleep like that. Like, in other words, even when you're sleeping, try to induce a good cervical curve, right? When you're looking at the computer, good cervical curve. When you're walking, try to keep your chest raised, right? The proper cycling, the proper running form is to lead with your chest. And for those who don't know it, I'm a 5-time Ironman triathlon finisher. Prolotherapy, the success rate with Ehlers-Danlos syndrome, in my opinion, is similar to other patients. Like I've said in previous videos, some of these, probably 10 years ago, probably with Ehlers-Danlos syndrome, they need a couple more visits than normal. Like, in other words, most chronic knee problems are 4 or 5 visits of prolotherapy. So Ehlers-Danlos, it might be 6 or 7 visits. But just know if the instability isn't bad, it may just be a couple of visits. 2 out of 3 people feel better after the first visit. 3 out of 4 people feel better, has some improvement after the second visit. I'm not saying that they're cured, but I'm just saying most of the people that I see on the second visit, they say they've already seen some improvement in their pain after the first visit. I have people with Ehlers-Danlos syndrome and other patients that I saw 20, 30 years ago, and they're totally fine. In 1993, 1994, I had 3 visits of prolotherapy on my ankles, and I have never, ever had ankle problems since then. I've done 5 Ironman triathlons, probably done 100 marathon races or marathon distance 26-mile running events or in training. So I can tell you, man, prolotherapy can last. Okay, this is an interesting case history that somebody sent, that they have weird dreams, wakes me up and I have tachycardia, sometimes in the 190s, but other times the pulse rate drops in the 40s. I'm just going to explain, like, when you go to a neurologist and you say some of this stuff, they think like, ooh, this person's a cuckoo. But I'm just telling you, this is classic for vagus nerve dysfunction. So in other words, there's 2 things, and I'll show a slide later on, but basically, when the vagus nerve gets damaged, that's called degeneration. But you could be sleeping in a position that's causing the electricity in the vagus nerve to be temporarily blocked. So when it's temporarily blocked, that's what shoots up the heart rate. That's what shoots up the heart rate. It's called a conduction block, and I'll show. So basically, yeah, I think this person, it's just that. And there are times where if you can't sleep because your head's getting in crazy positions, then you got to use a collar at night when you're sleeping, just to keep your chin away from your neck. So if I was going to say this person, I'll bet you that they have an elongated styler, they have significant upper cervical instability. So when they turn a certain way, it causes stretch and compression of the vagus nerve, and that's why they have tachycardia. Oh, this is okay. So here's the figure. So let's just look at this. This is normal. This is conduction block. This is degeneration. So it means that if you have stretch and compression on the vagus nerve for a long enough period of time, the vagus nerve is going to get smaller, smaller, smaller. The way you document that is you get an ultrasound of the neck. So it's called an ultrasound of the neck, and they measure the cross-sectional area of the vagus nerve. The vagus nerve cross-sectional area, and cross-sectional area is the area of the whole circle or whatever is the configuration of the vagus nerve. It should be greater than 2 millimeters squared. So in other words, cross-sectional area is diameter times diameter. So if you have vagus nerve degeneration, it's smaller, and you guys can Google, right? There's lots and lots of different conditions that cause the cross-sectional area to go down in our patient population, it's something like 90% of the people have vagus nerve degeneration when we test them. Occasionally, we'll see vagus nerve conduction blocks. Like, in other words, the vagus nerves are good, but they're getting a conduction block. So you could sleep in a position where there's stretch and compression on the vagus, and it's just blocking the vagus input to the heart. Well, the vagus nerve slows the heart rate, right? So if the electricity can't go to the heart from the vagus nerve, the heart rate can shoot up to 170. It's usually about 170. So if you take the vagus nerve out of the heart rate normally will go up to like 170. So my neck pain has gone away, but it is normal from my back to now feel very stiff while also affecting me mentally. Okay, so basically, instability in any part of the spine can affect the fluid flow into and out of the brain. Like, you hear me all the time talk about the jugular vein, but realize any sort of structural problem, like in the lower back, thoracic, or neck, can block the cerebral spinal fluid. So the effect's the same. So in other words, if you block the cerebral spinal fluid, it surrounds the spinal cord, it surrounds the nerve roots. So any sort of block then can raise the brain pressure and affect a person mentally. What some people do is called craniosacral therapy. So some people, that can restore cerebral spinal fluid flow. Realize the lumbar spine and the neck, they both have a lordotic curve. So if you are a person who slouches, it's likely that you've lost the lumbar curve and the cervical curve. This is very easily tested by a lateral x-ray, and you can get that anywhere. So if you want to know like what status your neck's in or your lower back's in, just get a lateral x-ray. It's just called a lateral x-ray, and they can do that, in any country. How can I heal and continue my life normally? My symptoms are mostly headaches, leg weakness, and vibratory sense. Oh, yeah, this is good. Okay, so okay, that's the question. Let's just look at this. I know that there's a lot on this slide, but it basically says that when you have structural neck issues or structural low back issues, it can affect the cerebral spinal fluid flow. It can compress the jugular veins. It can cause vagus nerve problems, the cerebral spinal fluid. If the vertebral artery gets kinked, what happens is you can get vertigo, you can get spinning, you can get drop attacks. And hopefully we're going to talk to one of my patients who used to have drop attacks. I think all of her drop attacks are better since she's been getting prolotherapy. And basically, ligamentous cervical instability can cause in my opinion, almost any eye condition. Excessive tearing, dry eyes, blurry vision, macular degeneration, retinal detachments. This is just an interesting thing that happened. I had a patient who I was treating, I think it was from Canada, and the husband had retinal detachments, like 6 retinal detachments on the one eye, and the first retinal attachment occurred after a LASIK surgery. So I've never had LASIKs, but I guess they put pressure on the eye, and it's very rare, but you can put so much pressure on the eye that a person has a retinal detachment. And I said to him, I'll bet you your jugular vein's blocked on that side. And the jugular vein being blocked on that side is the reason why the retina keeps detaching. And sure enough, that's what we found. It was the jugular vein was blocked on that side. So then we showed him the things to do to unblock the jugular vein, like what side to sleep in and what exercise to do. And then he got prism glasses. So prism glasses are glasses that have a mirror and you look down. And he did that, and the last repair is taken. So it looks like it's going to finally repair. Yeah. So there's a thing called the gastrocardiac reflex. So the gastrocardiac reflex, this is what I think causes it. And there's a condition called gastrocardiac syndrome. I had a new patient recently that had that. So basically, they're having so many digestive problems And when the stomach bloats or they get nauseated, all of a sudden they get tachycardia. So this explains that, in my opinion, that's caused by vagus nerve degeneration. So if you have where your digestive symptoms correlate with getting tachycardia or heart problems, you likely have this syndrome from a vagus nerve problem that likely is from your neck. So you have to get your neck structure corrected and it has to get stabilized. Lots of people have hearing problems. It's just going rampant, right? In the United States, it's unbelievable. You go every 2 blocks, there's a new hearing aid place, and they're popping up all the time. Like, why all of a sudden? When I was growing up, there was almost no hearing aid places. Now they're all over. Like, why are people having so much ringing in the ear, so much tinnitus, so much dizziness, so much hearing problems? Well, if you see how the jugular vein is right by what controls balance in the body and right by the cochlea, which is where you're hearing. Like I said in a lot of videos, if you have a symptom and you also have a history of self-manipulation, or your symptoms occurred after you got a high velocity manipulation or a trauma to your neck, or after COVID, it's likely that there's a neck component. So basically, so what we do, as you know, is we do digital motion x-rays of the neck, show the instability, and then we do prolotherapy to stabilize the neck, tighten the ligaments. Then normally with curve correction, the jugular veins open, and once the jugular veins open, the hearing improves, the tinnitus improves, and then obviously the person feels a lot better. Any sort of crepitation in the neck is completely abnormal. So that's a classic sign of instability. If you look at articles, scientific articles that I've written, there was a bunch of papers that I wrote, some like 15 years ago, 20 years ago, that related to a charity clinic that me and my staff ran in a very poor area of Illinois called Thebes, Illinois, for anybody who knows Illinois. And we published data on 702 patients. And overall, the crepitation or the creaking of the joints decreased about 75% with prolotherapy, so about 75%. Can jugular vein compression affect the heart? Well, basically, I think it does it by the vagus nerve. Remember, the vagus nerve runs right next to the jugular vein in the carotid sheath. So you can't tell definitively that the vagus nerve itself's getting compressed, though on ultrasound you can see the vagus nerve. Like we could look at the vagus nerve right here and it's nice and round. Then you look right here and it's like this, like it's like a pancake. And then when you go up here, you can't even see it. It's getting so squashed. But objectively, because the jugular veins are so much bigger, that's why you hear me say jugular vein compression, jugular vein compression. So if you want to know if your carotid sheath, the spinal accessory nerve, vagus nerve, let's see what else, glossopharyngeal nerve, vagus, jugular vein are getting compressed, you look at the jugular vein. So basically, ligamentous cervical instability affects the vagus nerve, and then the vagus nerve, if you research Google and you just type in vagus nerve and atrial fibrillation, you'll see all kinds of articles. So I think when people don't have a structural heart problem and they have an arrhythmia, I think you got to consider that the arrhythmia might be from the neck. And there's a local cardiologist that pretty routinely refers me patients that he thinks the heart problems are related to the neck. So there's a 64-year-old with hypermobility EDS. They have vagus nerve issues. Oh, they're saying that their Adam's apple or thyroid cartilage moves up and down with the pulses. There's something you've seen before. So basically, here, let's look at this. So there's two fulcrums of movement in the neck. Rotation rotation fulcrum, that occurs at C1, C2. But flexion, which is the more common one, is what? Because everybody's looking down at a cell phone. So when you flex your neck, the motion primarily occurs at C4, 5. The Adam's apple is at C4, and then you see here the carotid artery is like at C4. So when you get flexion instability, and this is what it looks like on digital motion X-ray, this is a still, so the person's going like this. And you could see that when the person flexes, this goes like this. That's what instability is. The ligaments aren't holding it together. So when you have what I call cervical cervical destructure means that the cervical curve is breaking down. So basically, when your neck, instead of going like this and it goes forward, what do you think happens? Like stuff gets pushed in the front, pushed in the front, pushed in the front. So sometimes the carotid artery gets pushed into the jugular vein. So guess what happens when your artery is pushed into the jugular vein? Then the pulsations travel up the jugular vein, then you hear them. That's what causes pulsatile tinnitus. So if you're hearing your heartbeat, that's totally abnormal. It's from a breakdown of the cervical curve. And so this person, their Adam's apple is going boom, 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 boom. So it's the same thing. Your carotid artery is getting pushed toward your Adam's apple. So cervical spondylolisthesis just means that on the neutral view, instead of the vertebrae being aligned, it's like this. So basically, would prolotherapy improve the spinal alignment? It normally improves the spinal alignment, the range of motion, but still the person's got to get their computer up, get prism glasses, work on their neck musculature. So this person doesn't want to get an upper cervical fusion. So obviously, I think there are times where I recommend a cervical fusion, but most of the time a person can just get prolotherapy. So this is just an illustration of prolotherapy. Oh, can degeneration of the vagus nerve cause pain all over and inflammation all over? You guys know the answer to this. I think the vagus nerve is basically the neurology of anti-inflammation. So if you go on Google, type in cholinergic anti-inflammatory system. So when there's vagus nerve stimulation, there's a lot of acetylcholine in the body, and that's basically the mechanism or the chemical mechanism, one of the main mechanisms by which the body gets rid of inflammation. So if you want to say, could lupus, rheumatoid arthritis, leaky gut, people who have high SED rates or C-reactive proteins, which are blood markers for inflammation, if they want to know, well, is there a structural issue maybe causing my rheumatoid arthritis or maybe causing my lupus? And I'm not in any way saying these autoimmune diseases are solely caused by structural issues. But if somebody's cleaned up their diet, you went on a gluten-free, dairy-free diet, and you have clicking, popping, grinding of your neck, and you got migraine headaches, you got all the signs and symptoms of ligamentous cervical instability. You have light sensitivity, sound sensitivity, touch sensitivity. You have, you got pain all over your body. You got to think of maybe you have a structural neck issue, which is ligamentous cervical instability. It's not normal to feel the sliding of vertebrae and cracking noises. That's a sign of ligamentous cervical instability. Fusion, neck fusion, it's normally reserved when you have an injury of your transverse ligament. So basically, if somebody does this, if they do this, and there's a separation of the atlas and the dens, they have an elevation in their atlantodens interval, that's when I would send somebody for an upper cervical fusion. But most of the time, prolotherapy can take care of it. Oh, mast cell activation syndrome. I know this. I just put that slide on there, or basically Michaela put that slide on there. We put that slide on there just that histamine has a function in the body. The mast cells are what release histamine. So mast cell activation syndrome is just there's way too much histamine being released in the body. So the question is why? Like, why is the body so inflamed? That's just this sign that it's inflamed. Usually it's because when you have vagus nerve degeneration, the digestive tract, the lungs in different places, the mucosa then gets leaky. Like, in other words, the tight junctions that hold the cells together aren't held so tightly. So basically, things that are supposed to not get in the body, like, in other words, you eat something, you eat food, and some parts of it aren't supposed to get in the body. Well, if your tight junctions are loose or leaky, then of course the immune system, including the mast cells in the digestive tract, get exposed to this and they release a lot of histamine. So I think I do have patients where their mast cell activation syndrome is completely resolved. And I'm not going to say that all the mast cell activation syndrome patients get it 100% resolved, but we do have people that where it's been resolved when their ligamentous cervical instability was resolved. Would it be beneficial to wear a collar once you're injured? So I think it's a good idea. You know, if somebody wonders, are there symptoms related to ligamentous cervical instability, you could wear a collar. The problem is most collars block the jugular vein. So you gotta have a collar like the Eclipse collar where it's open in the front. And just because your symptoms aren't resolved by that doesn't mean you don't have ligamentous cervical instability. So it is something. The other thing you guys can do is you can do the Quenkenstad test or the jugular vein test. So the jugular vein test is, you literally can just take your finger and you can block your jugular vein on one side for 30 seconds or a minute, the other side 30 seconds or a minute. You could block both of them and just see, does all of a sudden, like if I did this, I would start getting head pressure. You know what I mean? So if I don't have head pressure, but if I did have headaches or migraine headaches, and I'm like, geez, if I block my jugular veins here and within like a minute or 2 minutes, I start getting a migraine headache, well, then you know there's a jugular vein component. Oh, myoclonus. Okay. So myoclonus is just that the muscles are spontaneously beating. Like, so I definitely have seen palatal, I mean, imagine like going like this in somebody's mouth and you just see the top palate there, it's just going boom, 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 boom. I've had people where in their ear they hear thump, 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 thump. So basically, there's two muscles that elevate the palate. There's a tensor veli palatini that's innervated by the trigeminal nerve. The levator veli palatini muscle that's innervated by the vagus. Both of those are affected by ligamentous cervical instability. The trigeminal nerve that innervates that one, that goes all the way down to C2 to C3, the trigeminal cervical nucleus. So ligamentous cervical instability can absolutely cause palatal myoclonus, and I've definitely had stapedius myoclonus in the inner ear. I've had palatal myoclonus get resolved when we got the neck structure good and the neck structure stable. Oh, you can do a flexion extension neck MRI. You can do flexion extension neck x-rays. They can see instability, but just know there can be false negatives. So sometimes you actually have to do a digital motion x-ray. So this person had atlas misalignment to 10 degrees on the left side. So it's on the left side. So it means that basically the atlas is rotated to the left. So when you're right-handed, you tend to look to the right, look to the right, look to the right. So if you came to my office, like we're in my office, this is the studio in the office, people think I'm left-handed because I put my mouse on my left side, because again, I was having this kind of an issue. So basically for this person, I'd say, why don't you have your mouse on your left side and just realize you have to probably look more and more to the left instead of be looking to the right. And then the other thing too is, how are you sleeping? So somebody's atlas, so probably this person has to lay on their right side. So they're probably, when they're sleeping, they're either laying on their left side or they're on their back and and they're looking to the right. So when you lay on your right side, you're mostly gonna turn your head to the left, which is what this person needs to get the atlas more aligned. Okay, case reviews. So basically, Marie, it's probably Marie, she had a C1, C2 fusion. It looks like, sometime recently, and then she's still having a bunch of symptoms. So she's still having a bunch of symptoms. So, okay, so basically, when you have a fusion, so the question always is are we going to get her on the line?
Yeah.
Okay, okay. So I'm just going to keep talking, and at some point, Marie will come on the line. What happens is, the question is, when somebody has a surgical fusion and their symptoms, some symptoms get worse or the symptoms aren't changed, this is the way I look at it. What I usually find is that the person has multi-level instability. So in other words, Marie likely had C1, C2 instability, that she got a fusion. So some of the things got better, some things didn't get better because she had multi-level instability. So the fusion just helped the one kind of instability. Hi, Marie. Mary Ann, how are you? Okay, so will I be able to hear Mary Ann?
You should be.
Okay. Can you tell the audience what things were helped after the surgery and what things weren't? Or what things got worse?
I would say that, it's difficulty like holding the head up. It's funny because my head is not as heavy as before,
Good.
but it's still like, it feels very hard to hold my head up.
Okay. Okay. Anything? Did a lot of your symptoms go away, or did some symptoms get worse?
Some symptoms went away, like facial pain, heaviness of the head. It's lighter, but I think that like now my lower neck is moving more.
Yeah, exactly. That's exactly correct. I think you know where I'm going with this, because if you fuse that, what's interesting about your case too is your surgeon actually knew about prolotherapy.
Yeah.
Yeah.
He told me about it.
Okay. Was he supportive of it, or he was neutral?
He said that like if I wanted to try, it's safe. He's like, it's safe.
Okay.
But he's like, I'm a neurosurgeon. I have a bias. He said that. But he was like, if you want to try it, go for it.
Yeah.
He said that.
Yeah. So basically, if you came to us, or if you're going to get some tests, obviously I'd recommend what you should do is you got to do some tests, whether it's flexion, cervical flexion, or a digital motion x-ray. You're going to end up seeing that you have some lower cervical instabilities. And then, I don't know if you work on the computer, but just make sure that your like most people don't realize, you really should be looking up. Like when we test people with their jugular veins, it's unbelievable. Like they'll have the computer, it could even be eye level or below, and they're all closed off. And if they just look up, it's unbelievable how much they open up. So basically, you have to strengthen your muscles, and then it's likely you probably had multi-level cervical instability. The neurosurgeon got rid of the main thing. So are you saying your panic attacks, the anxiety, the fatigue, the head pressure, did that get a lot better after?
No.
Okay.
No.
Okay. So you probably still have some jugular vein compression. You probably still have some cerebral spinal fluid blocks, but just know the prognosis is very good. So
thank you. I can't wait to get to you.
Do you have any questions, though? Do you have any questions specifically for me? I thought your case was good because you didn't have a fusion.
So,
okay.
My upper MRI, he diagnosed me with AAI via a DMX, and my upper MRI showed C5 and C6 moving 3.2.
Yeah, it's pretty.
Is that instability? Because my neurosurgeon's not responding to my questions. I'm like, is that instability? Is that why I'm still like not good?
That's all. The prognosis is very good. Probably, with that amount of instability, I'd say you're probably going to need about 6 or so sessions of prolotherapy, but something like that. But thank you for letting us talk to you, and it's a very
Oh my gosh. No, it's a pleasure.
well
I'm very happy.
Marianne. Thank you so much.
Thank you.
Okay. And then Paula, we don't know if she's gonna.
Yes, give me one.
Okay, Paula. So here, what's interesting about Paula's case is she actually had 2 Eagle syndrome surgeries. So in other words, she did have surgery. So this would be a good case to talk about Eagle syndrome. So 50% of the people that come in, about 50% of the patients that I see actually have elongated styloid. So elongated styloid is a styloid bone over 25 millimeters, and that can obstruct the jugular veins. So we do testing in the office on the jugular veins to see if the styloids are a problem. Most of the time, they're actually not a significant problem, you know, in the patients that I see. When they are a significant problem, then I'll refer them for a styloidectomy. So this person had styloid surgeries. They removed them, and then she had an orthotic device that was for her jaw, hopefully to more align the jaw and open up her airway. And then she's just saying that she still had some pieces. So I just want to talk about that. So in other words, her doctor, she's not going to be able to be on the line, but we'll discuss her case, and I hope she feels good or feels better.
I'm here.
Oh, you are.
Sorry.
Is it Paula?
Yeah, Paula is fine. Yep. Thank you.
Paula. Okay, Paula. Thank you for being on. I'm sorry that you're having a rough day today. So can you explain to us, when you have a rough day, what symptoms are you having?
Yeah, mainly it's head pressure, nausea, feeling like passing out, blurry vision, vomiting. It's pretty rough. Heart issues, tachycardia, heart palpitations. Some days it's like, I really don't even know if I'm going to make it through the day.
Okay, so I'm assuming you're very familiar with CT venograms, right? So I'm assuming that your CT venogram showed a left transverse sinus stenosis. That's why you got a stent. And at Johns Hopkins, the CT venogram showed that your jugular veins were blocked. Was that what it showed? And then you had the stents placed?
Yes, exactly. It's just I wish I knew about all of this sooner. I was in this for years, and they found the eagles, and they found eventually the vein compression, but no one ever said, hey, your neck is unstable. I didn't know that until much later. So, they put all the stents in, but then they found that my neck, the C1, is still completely crushed in. My stents, so they're crushed in now.
Yeah, so so for the audience, you could see why Paula's case is one we have to discuss. So, and I appreciate you just being so honest with everybody and open with everybody. Let me just ask you a couple questions. When you lay down, what percentage of your symptoms get better, would you say?
Yeah, I feel the best usually at night. Like I wait all day to lay down at night. Most of them get better, to be honest, but sometimes I do wake up during the night, like you just discussed, with the heart palpitations and feeling like I'm suffocating. It's awful to wake up to that feeling.
Yeah, so let's just talk a little bit about that. So remember I talked about, Paul, I talked about the conduction block of the vagus.
Mm-hmm.
So what happens sometimes is the vagus nerve innervates the muscles in the vocal cords that keep your airway open. So you could see where if Paula has ligamentous cervical instability and she gets in certain positions at night and the vagus nerve conduction gets blocked, the vocal cords will close, and to Paula, it'll feel like she's suffocating. So that, Paula, that's likely what's happening. I just want to talk a little bit about Eagle syndrome, and I want to talk about why I try to get people better without getting stents. Is that okay?
Yeah, no, I really appreciate it. Thank you.
Okay. So long story short, so if somebody has a styloid and you feel like it's causing the problem with the jugulars, it's important to go to a doctor who does styloidectomies, who's skilled at taking out the whole thing. So the problem is Eagle syndrome, when it just causes pain, when the styloid just causes pain, you could just take off the end of it. But if the styloid is compressing the jugular vein or it's compressing the carotid sheath, in our office, we have people where they don't even have big styloids, but that little nubby thing, it's still compressing the jugular. So it sounds like in your situation, by your own thing that you said, that to you, even though you have a stent, it just seems like there's something around the atlas or that little nubby thing that's still occluding the jugular. So basically, in our office, what we would do is, beside we would do a cone beam CT scan, because you and I would be able to see how much of the styloid remains. But basically, what we do is we measure the jugular vein cross-sectional area when you do different motions, and to try to figure out, is it the atlas or is it that nubby thing? And in your situation, it sounds like it's probably going to be the ligamentous cervical instability, the upper cervical instability. So, and the thing is, some of the doctors, I think, could do a little bit better job of telling patients that when you have ligamentous upper cervical instability, like you have instability up here, it's usually a lot of visits. It's not just like one visit. Like some cases that I see, it's 12, 13 visits, because there's so much instability. Like prolotherapy can only tighten it so much per visit. Does that make sense?
Yeah.
But I'm sorry that you're having those things, but it sounds like you're on the right road. Like just go the route of the ligamentous cervical instability. It sounds like you got classic cases, and your case illustrates if the underlying cause is ligamentous cervical instability, even if you get stents, even if you get styloid surgeries, you know what I mean? Like everything flows through your neck. So the more important thing is to correct the neck structure. So I just encourage you as much as you can to try to, use your neck muscles, get some comprehensive prolotherapy. You don't necessarily have to get PRP. You could just we use a sclera, which is a substance. We use a sclera and dextrose, and we do, like I said, we do the whole posterior ligamentous complex. But it seems like if you get your neck curve as good as you can, keep working on your neck curve, and you get it stable, you should feel a lot better. But I'll answer any question you have.
Thank you. Yeah, no, I really appreciate it. Yeah, I guess you're just great, because honestly, I've seen hundreds of doctors, and I can't tell you like hundreds, and they just they don't know, they don't know anything. And so you're really very, very knowledgeable, and I really appreciate you, and I wish this knowledge was out there. For
together,
more.
we're going to do it together, right? I'll do my part. You guys just keep, go on the chat rooms, and you got to let people know that, you go on these different chat rooms, and you could go on a Lyme's chat room, and it's like, you got to say, it might be your neck, all these symptoms. You guys don't know this, but when I said I did the charity clinic, with my staff, we did it from 1994 to 2005. It was on a Lyme's disease belt. So it didn't take long for all these patients who were told they had chronic Lyme's to figure out that there was a charity clinic where you get prolotherapy for free. So we did this from 94 to 2005. And most of you know that I'm a Christian, so I try to emulate the goodness of God, through Jesus Christ. So basically, the Lyme's patient would come with all the symptoms like you say. They'd have head pressure, they'd have light sensitivity, they'd have their hearts going boom, boom, boom. They get dizzy all the time, and we would just do prolotherapy in their neck, and it was amazing how many of their symptoms went away. So you wonder if some of the tests that they do for Lyme's, they're showing up positive, but it's a false positive. The real symptoms are from ligamentous cervical instability. But Paula, thank you so much for sharing your case, and we wish you all the best.
Thank you for your help.
Okay,
Thank you.
Okay. Then, are we going to get Annie on the phone?
Yep.
Oh my gosh, one of my patients, Annie. I didn't review Annie's case ahead of time, so Annie will have to tell you her case. So she'll have to tell us how many visits. Oh, hey, Annie, how are you?
Hey, Dr. Hauser.
What made you want to go on this webinar? Like, what was it? Are you going to grill me, or you going to say some
No,
things
people
about?
have to know that it can really change your life. Like going through prolotherapy with you and doing the home exercises and all that went into that program, like literally gave me my life back.
Why don't you tell your history? Like, give a 2-minute version of like how bad you were when we first started, and how many sessions have you had?
Sure. My mom found you on YouTube, and I got diagnosed with EDS in 2018. I was 35. And at that point, I was pretty debilitated by migraine and migraine related symptoms. I had occipital neuralgia, I had neck pain, neck fatigue, other facial nerve pain. Light sensitivity was getting worse and worse and worse. I got pink glasses. I couldn't sit this way and look at a friend in a conversation for more than a couple minutes, or else it would just trigger all the symptoms. And that's just what's off the top of my head. Um, my migraine impact score was it was in the 30s.
Wow.
And so I really was desperate to try anything. Um, and I think I've come for 9 appointments with you.
Okay.
And I would love to come for a couple of more, but we're out of state. So it was a big commitment to come down every 4 to 6 weeks. But wearing the Eclipse collar helped me function more, get through the day. Still had to rest, lay down and rest. Like before prolotherapy, I could not fold laundry and chop vegetables for dinner on the same day. Like I really had to budget because I just couldn't hold my head up like your last person was saying. So I hosted 12 people for Thanksgiving, and I cooked for hours a day, multiple days in a row. And at the end of the week, I was like, I think I need to lay down and rest my neck. And I just could hardly believe how much better I feel.
Here, your case brings up a lot of good points. Like, in other words, you say, like, my snoring resolved, like my snoring, like you got to realize
Yeah.
like the airway goes through the neck too. The esophagus goes through the neck, the thyroid's in the neck, right? How many people have thyroid issues and nobody knows like what's causing the thyroid issue? And then, like if you go to the ophthalmologist and you talk to them and say, could my, light sensitivity, could my blurry vision, I don't know, did you have any blurry vision or no?
I have other vision issues related to probably EDS. But I was working with a neurologist with these symptoms who was very helpful, but couldn't get me all the way there. And he, with the light sensitivity, he said, you must just have one of those sensitive brains.
Yeah,
I was like,
the problem is, people don't realize like the hearing is in the brain, the eyes are actually in the brain, and balance your vestibular nerve, it's in the brain. So in other words, anything that raises brain pressure, right? And you hear me over and over again on the YouTube saying it's the jugular veins that drain the brain. That's what drains the brain. So the problem is if your jugular veins get blocked, it's probably gonna affect your eye, which is in the brain. It's gonna affect your hearing, that's in the brain, and it affects the brain also. Talk about drop attacks. We haven't really talked about that. So explain that, and how you doing with that? Like, what's a drop attack?
yeah. Well, I was walking up the stairs at my house and I just fell. I didn't lose consciousness. I didn't drop out. my legs hadn't felt weak. I had no idea what happened. And my family we had dinner guests, and my family looked at me and I was like, I tripped on the dog. I'm fine. It was terrifying. And, I talked with my doctors about it, and they all just kind of noted it in my file and like moved on. Like there wasn't anything to do about it. So, um,
Yeah, usually we find that that's the vertebral artery, which is in the cervical vertebra. We usually find in some people when that gets kinked, you can all of a sudden have a drop attack. So I've actually had one drop attack too. So I can tell you by firsthand experience, man, that is like scary. Boom, 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 boom.
yeah.
When your jugular veins get blocked too, it usually affects your memory or your problem solving, or it causes like unbelievable fatigue. So
Yes.
do you have any of that?
Lots of brain fog for sure. Periods where I'd be having a conversation and be like with my husband and be like, I just cannot process what you're saying to me right now. It's just like not computing at all.
Yeah, and that's a lot better, right?
Much better.
Here, just out of curiosity, does anybody have any questions for Annie? Because she's been through the prolotherapy, been through the curve stuff. So if anybody has any questions for her, but I
Yeah.
appreciate you
That's an
coming
open
on.
book.
A lot of people don't realize like that migraine headaches, right? It's so common to have migraine headaches, and there's hormonal things that can cause migraines. There's food sensitivities, but if
Hmm.
somebody's done all that stuff, so in other words, if somebody, back in when I first started, if somebody had neck pain associated with the migraine, that was always uh, a sign that it's likely prolotherapy is going to be very effective at resolving their migraines. And even Marion, my wife, she says her migraine started the day that we got married. But you and I know that can't be. I'm so wonderful. But you know what I mean? Like even her, she hasn't probably had a migraine in like 15 years or 20 years. So prolotherapy in some cases can be curative for migraines.
I still take a
Any questions
preventative
for Annie?
every other day, which is really great. But I checked when I was writing all this stuff up and for Michaela, and my Midas score, remember I said it was 37 when it was the worst?
Oh,
Zero.
that's
So
amazing.
they happen, but they're not ruling my life anymore, and I'm really grateful.
Okay, she's going to ask. I guess you got a question. See, I'm going to turn
Great.
you. Like you might as well just do the rest of it. Okay, go ahead.
Okay, this is Mary Ann from before.
Mary Ann's got to ask a
So
question.
she has a question.
Yeah, what is it? Okay.
It's about like how prolotherapy helped her hold her head up, like how many rounds. That's something that really
Yeah.
bothers me right now, because you can barely function. You have to lay down a lot if you can hold your head up.
Yeah.
Yeah, so yeah, like how many rounds after, like, did you start seeing improvements? And is it much better now?
Yeah. Well, I will be honest, after the first appointment, that first month was hard because you do a lot of movements for the different tests. Like he was saying, putting your head in different positions to do like the ultrasounds and the digital motion x-ray. So, but also they provided or recommended the cervical collar, like the right kind,
Uh-huh.
instead of the squishy foam thing that just like suffocates you. So that gave me a lot more stamina having that support because I wasn't having to hold it up. I had that external support.
Hmm.
And then by the third appointment, after the third appointment, I noticed a big difference.
Okay.
Yeah. And so then each appointment going on, so I had 9 total. But and my last one was December of 2023. And since February 2024, I've hardly put the collar on, maybe just a couple of times.
That's amazing.
Yeah. And I go some days, full days without laying down to take a break. I'm tired at the end.
Uh-huh.
And some days are harder and I still need to rest. Or use my prism glasses when I'm like doing my reading or phone calls or computer work. So that's still, it's not gone, but it's like 85% improvement. So much better.
Oh, that's amazing. I'll
Yeah.
take it at 85.
Yeah, right? I'll take it.
Yeah. Amazing.
Annie, I think you're like the typical person because at some point you're doing so good you know what I mean? I'd say my average client is that way. Like they'll get about 80, 90% better. You're doing really good. It's hard to like, yeah, you're going to fly in and da da da. But you got to realize probably too that a lot of you like probably your anxiety is so much less because now if you got in a car accident or something happened, you always know there's always prolotherapy, like so you don't have to worry
Right.
anymore. And but
Yeah, I'm still hoping for roller coasters, Dr. Hauser,
yeah, exactly. Here,
in the future.
I got one more case study that I got to go over, but thank you, Annie, so
Yeah,
much.
good to see you.
Seeing you again. Great seeing you. Okay, thank you so much. And then we have Mario. So basically, what's interesting about Mario's case for a lot of different things, when you try acupuncture, you do physical therapy, you do chiropractic, you do massage, you do medications, you do steroids, you do muscle relaxers, you do Botox, and nothing resolves it. It just means that probably the tissue that's causing the problem, like ligament tissue, it's actually the cause of it, and all these things like acupuncture is not going to cause ligaments to grow. Chiropractic adjustment doesn't cause ligaments to grow. So the person started prolotherapy, not by me, but by somebody else. Is Mario going to get on or?
Yeah, yeah.
Okay, so Mario, not by me, but
Hello.
oh, hey, Mario.
How you doing?
So the prolotherapy that you had, I suppose you had it in California, right?
Correct, in Santa Monica.
Yeah, with Dr. Fields. Then so basically the neck pain got better, right? But you still have a lot of different other symptoms. Why don't you go through the symptoms?
So basically, like the worst part is the brain fog, the anxiety, the depression. I mean, I have like a happy family. There's nothing to be depressed about, but it's something I can't control. Today I felt motivated because I knew I was going to be part of, this meeting. So there's certain things, in my life. I was like, oh, it's like a relief. When I go to my appointments, I feel less anxiety because hopefully it's going to work. And then a few days later, I go back to feel anxiety because I still feel the same. So, the chronic fatigue is the worst part. So I wake up, I go to the gym, and then by 2 o'clock, I'm dead, and I feel bad for my kids because I get home and they want to play, and just I have no energy in me.
Can I ask you something? Do you know what shape your curve is in? Like, do you have a good cervical curve or you have no idea?
I know I have a scoliosis in the top. So, and then my shoulders are off, my hips are off. One leg is a little shorter than the other. So I see that's like real obvious in the mirror.
This is a little bit odd, but there are cases where, like you would think, like if you have ligamentous cervical instability, you would think a person would have neck pain or they would have neck stiffness. So I just want to talk a little bit about that because you can still have ligamentous cervical instability even though you don't have neck pain. So I just want to talk a little bit about it. So you don't have, do you feel a tightness real high up? Do you feel a tightness high up? Or if somebody was to push on it, like if I push on this, pretty much it's not like sensitive way up here. Like, do you have touch sensitivity up here or do you have stiffness up there?
Not anymore because I went to an upper cervical chiropractor. I'm not sure if you saw the imaging, but it was off by 2.2 millimeters on the C1 and C2. So she adjusted it. I would fall out of alignment. I'd go back. She readjusted. Then I took a break from it, and then I went to go get prolotherapy to try to straighten up the ligaments. I went back and my C3 was off, which was causing a lot of anxiety. So she readjusted that.
When he adjusts you, did your symptoms get better or not really?
No, it's just like the anxiety level went down because I had hope.
Okay, I got you.
mm,
Here, what it
but
sounds like there's a couple things that it could be. Okay, so one thing it could be is that you have upper cervical instability because there's some doctors they don't do shots at C0, C1, C2. So that it could be that, or you have to have a lateral neck x-ray and you got to get your cervical curve really good. So I'd really encourage you to as much as you can to do the things that you need to do to get your cervical curve. Like
okay.
So just work on your cervical curve. Then with your doctor, there are times where you have to go to a prolotherapist that does the upper cervical. Like some of the doctors, they just do the lower cervical and they don't do the upper cervical, because it sounds like if you had atlas adjustments and you were going out of alignment, you got to go to like a doctor like me that does the upper cervical.
Oh,
Okay.
okay.
Great talking to you. Thank you
Thank
for
you.
volunteering. Okay.
Thank you.
Okay, and then
Okay, so we have Matthew.
He's
not. Matthew and Chad are not on the slides, but they would like to talk.
Matthew and Chad. Okay.
So I'm gonna get Chad.
Okay, while she's getting another person to chat, Mario just talked to us about that he has the CPAP every night. I just want to show you some things. Can you see right here how you could have a terrible curve and it's blocking the airway? So Annie, right, she got her cervical curve very good, and then her airway and her snoring was fine. So if you're somebody who clenches, a lot of times the clenching is the body trying to get oxygen. So sometimes it's the body's trying to get oxygen, and sometimes the obstruction is basically because of the bad curve. So, and then, hey, Matt, how are you, bud?
Chad.
Oh, Chad, you changed your name to Chad? No, just joking, just joking.
Thank you for
Yeah,
taking. So,
what's your question?
during COVID, I experienced vertigo. It's the only time I've had it. And so we had a physical therapist online that was helping my wife do the Epley maneuver for me. And I would kind of whip myself off the couch violently. And after about 4 of those, my C5 really started to hurt and I just didn't feel balanced. So we got an MRI. They showed some stenosis there. But my clinic wanted to do Prolo in my facet joints, C2 and C3, because of my dizziness.
Okay.
So when it first started, Dr. Hauser, I could touch C5 and create vision jumping. It was always left to right.
Yes, sir.
And a lot on the pivot, I would have the drop. And so the first Prolo was like a miracle. I had Prolo, C2, C3, both sides. That afternoon, maybe this wasn't smart, but I was playing ping pong with my teenage son. We play hard grip, total rip. It's on my affected side. The second Prolo was 16 days later. And in the follow-up, I'm asking questions like, are you sure you hit the right spot? Did you use a longer needle?
Yeah.
The third Prolo, I woke up and I'm using the walls to balance me.
Wow. Okay.
And it took me about a year to get through that. And so I'm still not better. Everything fatigues out. Mornings are good. Nighttime, I'm like totally drunk, even though I'm not drinking.
No, your case is just an honest case. So like, long story short, your case, Chad, illustrates that honestly, 1 or 2 millimeters, like think about how much you're changing your vertebrae just by pushing on like C5. So in other words, your case really illustrates you're so sensitive. Like if you have spinal stenosis, say you have spinal stenosis at like a little bit at C5 level, let's just say. So in other words, just a 1 millimeter turn here or there, it then all of a sudden you get a CSF block, and then all of a sudden you get all these crazy symptoms, right? So basically, that's why I think it's always good to have objective testing of what needs to get prolotherapy. Like in other words, like I don't know if you had any testing that showed that you had C2, C3 instability or C5.
Not really. It was more of an inference, I think.
Yeah, so I wouldn't get discouraged in the sense, I know you had kind of like a rough course, but I mean, your case just illustrates, like, I'll give you an example. Somebody might be able to be off quite a bit and they don't have any symptoms. But if you have a genetic thing, kind of a big guy, but maybe, Peyton Manning, had cervical stenosis, like some people, they just don't have as much room. The average person has 2 or 3 millimeters between the spinal cord and the bone. Like you might have just had 1 millimeter. So basically, when you got your first Prolo, the thing opened up like 1 millimeter. And then you're like, oh my God, this is like unbelievable. But then the next time again, it got constricted again, the 1 or 2 millimeters. So you should be able to get better either by getting your curve good. So please work on your neck structure, so you get a good neck curve, because sometimes that gets the spinal canal open. And if you have neck stiffness and you have clicking, popping, grinding, it's likely you're probably going to need some more prolotherapy. But if you don't have any clicking, popping, grinding, you don't have any neck stiffness, and you just have, neurologic symptoms, it may be you just need to get your curve better.
I don't have clicking, but this is always iced or heated. It always hurts.
It sounds like you need
touch.
prolotherapy. It sounds like you need prolotherapy like C4 to like C7, like the lower part.
And just a quick follow-up, because I know you got more. When I go to the Seattle doctors, what they say is C4 or 5 can't cause dizziness, and they ask me questions about my hands and arms based on that. Can this area? I think I experienced the dizziness here when it's really happening poorly for me.
What I think is confusing about your case is they're correct. It's usually the upper part. But remember I said, here's what I'm thinking was your pathophysiology. You have a narrowed canal C4, C5, C6, right? So you just need a smidgen of rotation of C4, C5, and you probably have 2 millimeters of instability. You probably have like 2 millimeters of instability somewhere between C4 and C6. So when you get a CSF block, unfortunately for you, it goes to your vestibular nerve, and then you get this wobbly thing, like it's horrible. And that's why the Apley maneuvers, they can't anymore get rid of it. So it's basically, you just got some C4 to C6 instability. So it's not the common thing that causes the dizziness at C4 to C6, but it definitely can occur. So I would just encourage you, at minimum, do flexion, extension x-rays, maybe get a flexion extension MRI, maybe get a digital motion x-ray. So Steve, I forget Steven's last name, but in your area, there's a guy, Steven, I forget his last name. He does digital motion x-rays up there. So maybe just get a digital motion x-ray. I'm sure you'll see that I'm right, that you got some instability there, and you just got to get some prolotherapy there. But in the meantime, just do your curve stuff, do all the stuff, for your curve. But I still think the prognosis is good. So I still would encourage you that I still think.
And when you say the curve stuff, like if I try and stay flat on the wall, I can't quite do it. My shoulders make it, but not. Are you saying that I'm curved forward?
That's exactly right. Like that's exactly right. And then, get prism glasses. So when you look at your cell phone, you're looking up. Then make sure if you work on the computer, you got to look high. Like in other words, most of us, if we're honest, we don't use our neck muscles. So just, when you're walking, just always keep your chest up and use your neck muscles. Like, you watch TV at night, instead of slouching, have some of the time where you're using your neck muscles,
Okay.
Hey, man,
thank you.
Thanks. Great.
I appreciate it.
It's great seeing you.
Hello?
Oh, hey, Jacob.
Hello.
You have a question?
Yes. Oh gosh, it's been a while. Oh, I'm almost home. Can you hear me?
Yeah, we can.
So it's been, I think we're going to go on 3 years now. I started to feel my heartbeat and I thought I was having like heart issues.
Of course.
So then I went to the doctors, and they said that my ears were plugged. And then I noticed like my voice sounds weird to me. But when I hear everyone else, everything else sounds normal. But to myself, it's like different.
Yes.
So then I went, they tried to put the tubes in my ears. And then they took them out, closed them up. Then they said I had sinus issues because they basically say eustachian tube dysfunction. So then they did balloonplasty, where they put the balloon through all your sinuses.
Yep.
And then it's been, I think, 6 months since then. Still hasn't corrected my issues.
Yeah, tell tell everybody the symptom. What's the symptom specifically?
So my main one was just feeling the heartbeat constantly. My ears were plugged, and
But
then I did.
are you hearing the heartbeat, or you're
I,
feeling it in your chest, or you're hearing it in your ear?
like I feel it. I don't hear it at all. I just feel it. Like it's in my chest. It's
Okay.
in the part like under or on the opposite side of your elbow. I could see my pulse bouncing like 24/7. So then I finally came across your videos and I went to see upper cervical chiropractor, and they do the Blair method. I had 2 adjustments. They said C1, 2, 3, and 4 all shifted to the left. I also have more like visual disturbances on my left eye,
Okay.
and my left ear is the most clogged one.
Yeah, like here's what I'm going to recommend. Start sleeping on your left side to open up your left jugular vein. I'm not saying for sure that that's going to resolve a lot of it, but
Right.
can you lay on your left side and then extend your neck? And then during the day, every 2 hours, do that for 5 minutes, that position, and just see if it goes down. If it starts going down, then you know you have compression of the carotid sheath on your left side.
So
Yeah.
so you would want to lay on that side,
Yeah,
because when I
lay on
do,
your left side, lay on your left side. That's what I would just say off the cuff. Do that, and then you probably should get a digital motion X-ray or something. You got to look for it if you have some instability, but at least try to lay on your left side, because that should, if you extend, it should open up your left jugular vein. Most people, that would open it up.
okay, I do notice when I do sleep on the left side,
Yeah.
that my left ear is like super clogged. Like it almost feels like someone's putting a giant Q-tip in my ear.
Okay, if that's the case, then what I'd recommend, you should see if a doctor will do a CT venogram of your head and your neck, CT venogram of your head and your neck, because it sounds to me like there might be, remember one of the patients or one of the people that we were talking to, I think it was Maria, she had a left transverse sinus stenosis that she needed a stent. So it might be that there's a venous obstruction, not just in the jugular, but in the transverse sinus. It's a very safe test, a CT venogram of the head and neck, because that will give you a 3D anatomy. But the other thing it can be is that you have, like your chiropractor, that you have instability. So just out of curiosity, do you have clicking, popping, grinding in the neck, and do you have neck stiffness?
Oh yeah,
Okay. And do you
definitely, and it's on the left side.
do you self-manipulate? Do you crack your neck?
Yes, I do.
Okay, so I know, but that's, like by definition, you have ligamentous cervical instability. So you're going to need to eventually try to stop cracking your neck, and eventually you're going to need some prolotherapy. So I think all this stuff, unless you get prolotherapy, I think it's just all going to be temporary, because if somebody who cracks their neck all the time, they self-manipulate, they just have so much instability. Okay, but thank you for Matthew had whiplash 7 or 8 years ago, neck stiffness. Recently, I'm having bad vision, dizziness, stomach issues, heart rate issues. I have degeneration at C5, C6. Do you think I'd be a good candidate to get treatment? So, you guys know from the YouTube videos that, boy, all the fluid flow that goes to the brain and to the body from the brain, it goes through the neck. And then basically, when you have jugular vein compression, and it's very easy to tell if somebody has jugular vein compression. So I just want to show this. So you see this is a neck, right? So you see this bone here, that's that styloid bone. So we do cone beam CT scan. So let's just say Matthew has a styloid. That would mean every time Matthew bends his head, he goes like this, he compresses the jugular vein on this side. So the problem is, let's be honest, most people sleep with the chin close to the neck. So the first thing for Matthew to do is please don't sleep with your chin close to the neck. And then if you have a job where you have to use your mouse, if you have like more right-sided symptoms and your mouse is on the right side, you got to move it to the left. So in other words, this is a styloid on the left side. So if Matthew has left-sided symptoms and he has a styloid and he rotates to the left, it's going to compress the jugular. What we find in the office when you have ligamentous cervical instability, your atlas goes forward. Here, I'll do it this way. Your atlas goes forward, and this is basically what we see. The atlas goes forward and compresses the jugular. When it compresses the jugular, inevitably, eventually, because it's a progressive disorder, right? You have a loose screw on a hinge, and if you don't take a Phillips screwdriver and tighten that screw, the next screw gets loose. So the way the neck goes, if you have one ligament injury here, and it starts with just a dull pain here, and if you just manipulate, you crack your neck, it's just going to be progressive. So that's why people will tell me, geez, I had some neck pain, and then it's almost like an atomic bomb went off, which I call a neurocatastrophe. Like, in other words, the body's going to do everything it can. The brain's going to do everything it can to survive, right? So if you start blocking your jugular veins, basically the pressure goes up in the brain, and the brain's going to go on basically self-survival mode. So what it does is it dilates the arteries, because the brain doesn't know the pressure is going to keep coming up and an artery is going to clog off, and then I'm going to get a stroke. So the arteries dilate. Well, when the arteries dilate in the brain, that gives you unbelievable anxiety, right? Your brain is under stress. Now, when you lay down, if you lay down in a position where your jugular veins open up, yeah, the anxiety can go down. But a lot of people, again, in other words, the problem is the atlas is pushing the jugulars. Well, when you put your chin like this, when you go forward, you're pushing the atlas more forward. So there's still jugular vein compression. That's why you have to get the atlas back. So you get the atlas back by extending your neck. So that's why being in positions like you're laying on your back and your neck's extended where your chin's away from your neck, it often opens up the jugular veins. And then, of course, the vision starts getting better, the dizziness gets better, and the stomach issues and the heart rate issues are what we talked about before, which often relates to the vagus nerve, which runs with the jugular vein. Both the vagus nerve and the jugular vein go into the brain at the exact same hole called the jugular foramen. So Matthew, if he can just get his neck curve good, obviously if he clicks his neck, cracks his neck, he's got to stop doing that, and then get an evaluation for ligamentous cervical instability, and then if that's found, get some prolotherapy to tighten the ligaments. So let's see. Oh, there's one more case, I guess. Okay, go ahead. Okay. Go ahead. We got another case. This is Colin. Okay, thanks, Matthew, for your case, but you sounds like a great candidate for prolotherapy, and you should do really good. So keep trying to get better. The prognosis usually is very good.
Colin is joining.
Oh, Colin. You don't get to meet a lot of Collins. This is going to be exciting.
Can you hear me?
Yeah. Hey, Colin. Thanks for being on.
I'm in Canada, and my mother refused C-section when I was born, and I was 25 and a half inches long.
Wow.
And labor was very long and very hard on her, but equally hard on me. And I had a lot of health issues my entire life.
Yes, sir.
Including my father, when I was a teenager, because I wasn't growing, felt I needed human growth hormone. Well, when I was 49, I was diagnosed with it by a doctor. And are you there?
Yeah. What symptoms do you have, or what question do you have?
Okay. So my real problems are, I had a whiplash incident 12 years ago. And instantly, my body went cold and I had high blood pressure.
Okay.
And since then, any kind of vibration, I can't drive a car because if I drive a car, the vibration of driving a car will cause high blood pressure or AFib.
Yeah.
And I did see a Nuka chiropractor, and when she did her manipulation, she thought I was so bad that she wouldn't be able to help. She did the manipulation, and instantly my brain was on fire. And I don't mean that in a bad way. I meant
almost like it started firing again, like it started working again.
It was hot, and it was just incredible. And I was, people used to say I wasn't happy, but I thought I was. I wasn't.
Yeah.
And then since then, I've been happy, but it's not holding any longer.
Right.
And so the problem is we switched meds, because the only med that worked for me was none of the blood pressure meds.
What I'm going to do is just to keep it going. What it is when you have a structural issue, you need a structural treatment, like something that occurred after a whiplash injury. Like obviously you had temperature dysregulation, likely from you have sympathetic dominance. So when you have sympathetic dominance, the blood vessels clamp down and you feel cold, right?
Correct.
When you have high vagal tone, right? Your vagal tone was so low, So in other words, you have ligamentous cervical instability that's screwing up your brain, screwing up your body. So I think you would be a very, very good candidate. Obviously talk to the Nuka doctor about, if you can't hold adjustments, you're going to have to consider, getting some assessments for ligamentous cervical instability. And then if you have it, consider getting some prolotherapy. And
I've talked to your office.
So much trouble. And the other thing too is ligamentous cervical instability, because the brain controls everything in the body. It's the central computer. So if you got jugular vein compression because you got a whiplash injury, or you were born, like your vagus nerve was all screwed up from birth, which it sounds like that might have been you, that, at any point, if you correct the neck structure, there's a lot of things that should get better with you. There should be a lot of things that get better with you. But I'd really encourage you, get some tests for ligamentous cervical instability.
I have it for sure. There's not even a question.
Yeah.
But the question, I've talked to your office, but the problem is I can't travel to Florida because I can't even drive a car 200 miles.
Okay, gotcha. Yeah, I know that's hard. Where are you located?
In Alberta, Canada.
Okay. Yeah. Like I know there's some naturopaths and stuff that do some PRP and do some prolotherapy, but it's usually by the time you got neurologic things that you usually got to go to somebody who's used to doing the upper cervical part. But at minimum, what you can do is like the other things that I talked about, make sure that you get your neck curve really, really good. Play around with just what position to sleep in, just to open up your jugular veins.
Well, this is an important.
Maybe get an eclipse collar, and just hold.
I'm wearing a collar right now.
Well, I'm just saying, get one that doesn't block the jugular veins. Get one that's open in the front. So, and then try where you lay, with your neck extended, like 5 minutes every couple hours, and just see if you get the fluid flowing good and the vagus nerve not compressed, that you don't feel better. But hey, we gotta go to the next.
Well, just one more thing, if I could. The problem is that when I lay down, the symptoms are bad, and I use a proper cervical pillow, and I can stop the symptoms by taking my head and putting it to my chin. My chin to my chest will stop the irregular heartbeat, or it'll stop the high blood pressure.
Okay.
By doing the exact opposite of what you normally would recommend.
Chin to the chest, chin to the chest. Okay. Well, as you know, there's lots of different structural things. Like you could be somebody where it's your jaw causing the structural issue, or it's not actually a jugular vein thing. It could be something in the brain. But it's interesting. It's interesting. But what they could do in Alberta, you could get a CT venogram of your head and your neck.
That's been ordered.
What? Oh, that's good. No, so just see what that shows, and then hopefully the NUCA doctor will interpret it correctly. But yeah, it should show where the compression is. So you probably likely, you may not have the classic Atlas thing. You may be fine with the Atlas, but it may be somewhere else. Like I have weird cases. Like I have cases where the blockage is down here, right? It's not up here, it's actually down here. Because, like when you go like this, a lot of times there's changes in the brachiocephalic, the subclavian. But yeah, but thank you for sharing your story.
Oh, you're welcome.
Okay.
Okay, your question, the next question should be on the slide if you flip to the next one.
Oh,
We have
okay.
two more added.
Okay, can you please touch on upper thoracic instability? Like obviously if somebody has cervical instability for a long period of time, it's a progressive disorder. So there's lots of muscles, splenius, capitis, and different muscles that go from here to here. So, when we're all hunched over, it's very common also to get upper thoracic instability. That does respond very good to prolotherapy. There are patients where we have to have them wear a brace. There's different devices they can get on the internet that go through various apps to check your posture. So again, part of slouching is ligamentous cervical instability, upper thoracic instability, and lumbar instability. Is this another one?
Yep, you have about 9.
In someone who had tinnitus 8 years ago due to hearing or developed hearing loss, you got to be careful when somebody's cracking your neck, and people who crack their own neck, eventually you're going to probably end up with ligamentous cervical instability. I've often said it's very easy to loosen something. It's very hard to tighten something, because to tighten something, you have to tighten the ligaments, and ligaments, they're white, so that you got to keep hitting them with prolotherapy. So you got to be careful with rotatory cervical manipulation. The hearing loss matches the tinnitus frequency. How can you determine whether this is cervical instability, dorsal nucleus damage, and disinhibition of the auditory center, or treatable with cervical instability? No, very, very good question. Sometimes we have to assume what the neurology is. Like, in other words, it's easy to surmise that if you got cracking, clicking, popping in the neck, that occurred after a lot of chiropractic care. And like the last Colin said, he knows he has ligamentous cervical instability. You have to assume that if you get the ligamentous cervical instability better, you get the jugular veins open, you get the eustachian tube dysfunction corrected, because you're correcting the neurology that's causing it by stabilizing your neck, that even if you have an issue in the brain stem or the hearing nerve related to the neurology of hearing, well, it all has a commonality as the cause. Like, what causes the hearing loss? Well, the hearing loss is likely caused because there's too much fluid in the cochlea, because again, if the jugular veins don't block, it means your hearing nerve's not going to drain either. Like, the nerve's not going to drain either. So just like if there's a block in a river, or there's a block in the highway, right? Everywhere you guys live, if there's a block in the major highway, all the streets going off of the highway are all jammed up. So if you jam up this, it's going to jam up everything here, including things in your brainstem, so your brainstem doesn't function right. So we just see at the Hauser Neck Center, I see so many different conditions that are supposed to be non-curable get amazing amount of benefit just by correcting the neck structure and correcting the instability. Can stem cell PRP treat grade 3 trochlear chondral fissure in the femur with subjacent delamination? So long story short, all this stuff is related to instability. I'm finishing a 2,000-page ligamentous joint instability book. You guys can start getting the chapters. So go to our website and you can sign up to get the ligamentous joint instability book. So on the chapter on the knee, I researched this to death, and it was unbelievable. When you get medial collateral ligament injury or you get anterior cruciate ligament injury, again, it's a progressive disorder. And guess what? The pressures of it, when you don't get those ligament injuries corrected, it goes right on the trochlea, and the thing breaks down. So the real question is, the cause of this is ligamentous knee instability. You got to get the ligaments tightened. So like I say in the office, if you had this condition on two knees, it's both of your knees. And on one knee, we do the greatest stem cell treatment of all time. We inject it right where these fissures are, and we don't do diddly squat related to the instability. In the other knee, all we do is resolve the instability, because by resolving the instability, the pressure on the trochlea is going to go away. So then it has a chance to repair. So the knee that we just treat the ligaments is going to do so much better than the one that we did fancy dance $10,000, $15,000 stem cell thing. This is why stem cell treatments at some of the clinics where they just do stem cells with everybody, it doesn't work, because they're not treating the ligamentous joint instability. They're just injecting this stuff where the labrum is, where the fissures are. Like, the main thing is you got to resolve the instability. So in the office, we might do stem cell, we might do bone marrow, we might do PRP, but the emphasis would be on the ligaments and to resolve the instability. So we show people that you have instability. So we do stress ultrasounds that show that the knee's going wah, 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 wah. And that's the thing that's causing the pressure, that's causing the cartilage to break down. So basically the clinic should be showing you the instability. You got to resolve the instability to resolve that. So I was diagnosed with autoimmune disease called multifocal motor neuropathy, where the myelin sheath is stripped off. The nerve can prolotherapy rebuild the myelin sheath. It's a very interesting question. It's like amyotrophic lateral sclerosis or motor neuron diseases. Like, when things are genetic issues, normally prolotherapy can help, but it's not curative. But there's some autoimmune diseases that I think are related to ligamentous joint instability. So the question is, what is this person's symptoms? Like, what is the actual symptom? Like, I'll give you an example. So if the symptom is primarily affecting, let's just say it's primarily affecting the perineal nerve, it's affecting, like, the person has foot drop or something. Like, in other words, it's just one-sided. It's not on the other side. Then you got to think that there is a joint instability component, and that if you do some prolotherapy, it should help with the symptoms. So a case like this, I'd actually have to review the medical records, because, there are cases where it helps a lot. In other cases, it's not going to help. But the more localized it is, the more likely prolotherapy is going to help. He's from the Philippines. I'm a general practitioner. Oh, they do prolotherapy. Great job. Prolotherapy in the Philippines. That's great. I have a patient who dislocated his shoulder, tenderness in the tendons. Is it sufficient to treat the whole delta, or do I need to go all the way? Okay, so we do comprehensive prolotherapy. So, doc, I'd say, to me, I would rather overtreat than undertreat. Like, you have a loose hinge on a cabinet door, and this one screw's loose, and whenever you look at the other screw's loose. So the cause of this is glenohumeral ligament injury. So we would do the ligaments here. Normally the AC joint needs to be treated. All the tendons needed to be treated. So I just encourage you overtreat versus undertreat. Like the odds are, by the time somebody has chronic pain in a joint, the whole thing's screwed up. Ligaments are screwed up, tendons are screwed up, joints screwed up. So you're better off treating the whole thing. Can your dynamic ultrasound show if you have a suspected brachial plexus injury where there is a hemangioma? Yeah, no, absolutely. So what you do is, like, on Doppler ultrasound, it can show all the blood vessels, and the brachial plexus shows up really good. So you really should be able to show, where the hemangioma is and whether or not it's causing, it's compressing the brachial plexus. this is what I would say to this person is, if you have clicking, popping, grinding in the shoulder and you have pain down the arm, it's probably related to ligamentous shoulder instability. Because sometimes hemangiomas, I mean, the amount of hemangiomas that we see on cone beam CT scan, it's quite common. Like, they're in the C4 vertebrae or whatever. And a lot of times they don't cause any problems. Like most of the time they don't cause any problems. Most of the time it's a ligamentous problem. And one could even make the assumption maybe the ligamentous joint instability in the shoulder was actually what caused the hemangioma. I am 2 months post C1, how long should I wait to get prolotherapy? What we do is we normally, once the surgeon says you're doing well, like whether it's the 1 month follow-up or 2 month follow-up, once they say, nope, you're doing fine, then you can get prolotherapy. And obviously, we're not going to do prolotherapy where there's a fusion. We do prolotherapy, like this person could still have C0, C1 instability, or they could have instability below where the fusion is. Can symptoms from cervical instability be irregular, not associated with specific head movements? If so, why? That's a good question. Great question. For example, the GI issues, blah, 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 why are those symptoms sometimes okay or tolerated if they are from cervical instability? Also, if you treat hypermobility, EDS, and make the ligaments stronger, will the thumbs not bend? Yeah, they could be. That you can do prolotherapy enough where it won't do that, but most people would just do prolotherapy till the symptoms resolve. The word instability comes from, I don't know if it's the Latin or the Greek, but it's instabile, which means changeability. So one of the hallmarks of ligamentous cervical instability or even joint instability is the changeability of the symptoms. Because basically instability means the bones are moving in ways that God never intended, right? God might have made the body where a joint is supposed to move this much, but with instability, it moves extra, right? All the nerves, the spinal cord, the nerves, the jugular vein, the carotid artery, they're all within a couple millimeters of the bone. So if you have instability, like the one patient said, oh, I have a 3.4 spondylolisthesis, that means the vertebrae are moving 3 millimeters more than they're supposed to. So what is that 3 millimeters going to do? It could block the CSF. It could hit the jugular vein, hit the vagus nerve. So basically, when someone's anatomy is reasonable, like in other words, the way they slept, because they have instability, it means that the vertebral position is very changeable. So it could change where it moves 3 millimeters this way, and you're like, holy crap, it's smashing my vagus nerve on my right side. Now my stomach isn't working, and I'm like nauseated all day. But then the next night, because we move around at night, the next night when you wake up in the morning, it just happens that the atlas went in the right position and you're like, geez, I feel fine. So that's that's why the neurologist would say the person's crazy. Like, why, like you're saying one day it's good, the next day you feel terrible, but that's common with instability. So that's common with instability. And then, okay. Can structural problems in the body be a cause of irritable bowel syndrome? And you heard me say lots of times, the vagus nerve innervates the bowels. So any kind of vagus nerve conduction block or instability can cause digestive problems. The other thing to realize, the valves, pyloric valve, sphincter of Oddi, ileocecal valve, a lot of the control of that's from the vagus. So if your ileocecal valve keeps opening when it's supposed to close and your colon bacteria goes into the small intestine, you're going to get small intestinal bowel overgrowth. You're going to get all kinds of irritable bowel syndrome symptoms. So definitely, neck problems can cause irritable bowel syndromes. One doctor diagnosed hypermobility EDS, another doctor said, no, I have hypermobility, I'm being treated for TMJ. Once my jaw teeth are treated and the jaw is able to rest in the correct position, can you then treat the ligament to help keep it in place? Yeah, absolutely. Absolutely, you can do that. So that's a definite yes. And then thank you, everybody. We covered a lot of stuff. You guys were great. You know, anything you think of, like if you think this was helpful, please let us know. If there's ways we can improve it, you let us know. Like, obviously, I just wanted to try this one time because I think it accomplished what I thought was going to happen, was a very interactive thing, because we're missing this. Like, you guys are my heroes. I might be one of your heroes, but you're my heroes because you guys are still in the fight. Like, you're still wanting to get better. You're not giving up. And I'm just telling you that ligamentous cervical instability, breakdowns of the cervical curve, it causes a lot of things, which obviously a lot of you have, and you have a lot of the control. You have a lot of the control. Now that you know what's wrong, you can get the tests that you need, and hopefully wherever you live, you can get the treatment. And if you can't get it there, obviously, I'm always here in Southwest Florida. It's a beautiful place, Fort Myers, Florida. And if I do end up seeing any of you, it'll be my pleasure. Love you all. Have a great night.